People are still joining, but I think we've got a good number here, so we can go ahead and get started. Welcome. Thank you for joining today. This is our first Research in Progress webinar in the new year. So Happy New Year to everyone. My name is Carrington Lott. I'm the Deputy Director at Systems for Action, and I will be introducing our team that will be presenting to you today. Before getting started, I did want to give a little overview for those of you who may not be familiar with Systems for Action. We're a national program office of the Robert Wood Johnson Foundation. We are housed at the Colorado School of Public Health in the Health Systems Management and Policy Department in Aurora, Colorado. We do lots of things at Systems for Action. All are focused on how to better align financing and delivery systems across the public health, medical, and social service sectors. One of our main activities at Systems for Action is developing and releasing generally annual funding opportunities where research teams can submit their innovative ideas of how they want to align systems in the topic area of their choice. And this team responded to a 2024 funding opportunity that we released, and this is going to be their first time presenting in our Research in Progress webinar series, which is our series where our researchers come and present on their research at the beginning and in the middle and at the very end of their research project. So you can get really live updates on their research findings and just keep up to date with what they're doing in their research. Since I mentioned funding opportunities, we are planning on releasing another funding opportunity very, very soon. It will be in the middle of January. So please check back on our website. If I could get my colleague Sadina Belmashkin to put into the chat for everyone to see our funding opportunities landing page on the Systems for Action website. You can read more about what we're looking to fund. And if you're on our newsletter, you will be the first to receive information about that upcoming funding opportunity. So back to our presentation today, which is the reason that you've joined. You're going to be hearing from the team at the University of California, Berkeley, and their partners at US Aging on their research project, which is titled Aligning Systems for Equitable Vaccination Access, if I can say it properly. And like I mentioned a few moments ago, this is their first time presenting in our Research in Progress webinar series. So you get to hear all about what they plan to do over the 3 years that they've been funded to do this research project. Can I go to the next slide, Amanda? We're going to reshare.
Oh, so will I stop sharing now?
Oh, no, you can go ahead and share. I was just going to go to the
Oh,
next slide, which had some housekeeping items on it.
great.
While you are resharing, I can just go ahead and go over those. Today's session will be recorded, so you will receive an email follow-up with the recording as well as a PDF of the slides. And Amanda, it may not be added yet, which is fine. So we will share all of this information with you after today, and then we do reserve time at the end of each of our Research in Progress webinars for questions and answers. So if any questions come up at any point during the webinar today, please feel free to locate the Q&A box at the bottom of your Zoom screen, put your question in there, and we will reserve time for it at the end. Okay, with that, I'm gonna hop off and hand it over to Amanda and her team so they can present on their research today. Thank you so much for joining.
Thank you. So I'm really delighted to be here on behalf of our team here at UC Berkeley. So we're presenting together with my colleague Jenny Quadams. We're really happy to have this chance at the beginning of our project to tell you what we plan to do. And we have also assembled some early descriptive analysis that we are looking forward to sharing. To give a little bit more introduction, so I'm, as I mentioned, based at UC Berkeley, and our team is located in the School of Public Health here at Berkeley. For my part, I'm faculty in health policy and management, where my focus is on understanding processes by which healthcare organizations and other types of organizations that attend to social services and other important dimensions of health work together. So looking at innovative ways that those organizations collaborate and partner. So we're really excited to be able to study the innovative work being done by the Aging and Disability Vaccination Collaborative, hosted by our colleagues at US Aging, who you'll get a chance to hear from in a little while. So let me also turn it over to my colleague, Jenny Guadamus, for an introduction. And then the way we're going to do this is Jenny is going to speak to the first part of our presentation, kind of taking us through some of the background and motivation and context for our project. Then I'll take over to speak to some of the pieces around our study design and some of the early descriptive results. Then I'll send it back to Jenny to speak to the pieces of our analysis that we've got ahead of us. And then we'll close up and hand it over to our colleagues, Tracy Wilson from US Aging and Jennifer Hammer from US Aging, who will provide some additional context on how the research is interacting with the practice-based work being done by the ADVC. So Jenny, I'm going to hand it over now to you.
Awesome. Thank you, Amanda. I'll give myself a very brief introduction. So again, I'm Jenny Guadamus. I am an assistant professor here at UC Berkeley School of Public Health. And my research is a lot broader, but in really, yes, to overuse the word broad strokes, my training is in pharmacoepidemiology and do a lot of work in health services research, focusing on how structural racism and broader structural factors influence access to medicines. And some of my specific populations of interest are people living in segregated neighborhoods. I also do a lot of work, which I'm not touching about here, but on immigrants and how they access the healthcare system. Next slide, please. But today we're going to be talking about something very specific, and which is that every year, respiratory illnesses claim the lives of thousands of older adults. For instance, during the 2023-2024 flu season, influenza resulted in about 28,000 deaths in the US, with 70% of those being among older adults. And similarly, COVID killed about 77,000 people, and 90% of those are older adults. And given the historical arc of structural racism and how illnesses generally pick out the people that are most vulnerable, minoritized racial ethnic populations, especially Black and Brown persons in Black neighborhoods, are more likely to die from these illnesses. However, the vaccinations can greatly reduce the risk of transmission and severe illness, which we're defining as ICU admissions. For example, the influenza vaccine can lower the risk of severe illness by more than 80%. And the COVID vaccine can do the same for about a 50% reduction. It could also reduce the risk of long COVID, which is not really talked about a lot, but it's very important to think about that. But one key thing to remember is that the influenza vaccine has to be administered every single flu season every year. And to ensure that the COVID vaccine is effective, individuals really should be receiving the most recently available vaccine, as those are specifically designed to combat the latest virus illness or virus strain, apologies. And about 95% of people that die from COVID do not have the most recent vaccine available, kind of pointing out how important these annual vaccinations are. But unfortunately, as of the last 2023-2024 season, about 30% of older adults did not receive the influenza vaccine, and about 50% did not receive the latest COVID-19 as of the current season, so 2024-2025. Next slide, please. And these, we talked about these kind of low or lower than ideal vaccination rates, but we also know that vaccination rates are even lower among minoritized racial and ethnic populations. And you see this across COVID vaccinations in the 2023-2024 cycle, and also influenza vaccinations. Next slide, please. And there's a lot of mechanisms that can kind of result in these inequities and result in barriers to getting these vaccines. And broadly, systemic racism can create these inequities through two primary channels. The first channel is that it suppresses a person's intent to pursue vaccination. So someone that's decided to, or the decision to actually vaccinate. And these can be things like targeted misinformation to certain populations, insufficient health information in a patient's preferred language. So if you're a limited English speaker and you don't have access to the information that you need in the language that you can speak and read, and mistrust based on past racism and discrimination and health encounters. That not just yours personally, but this long arc of medical racism leading to mistrust. The second way that systemic racism can operate through these channels is preventing a person's access to vaccines once they intend to vaccinate. And this can happen through, if we think about the social determinants of health and how economic resources are racialized, the distribution of them, and these lack of these economic resources can result in practical barriers to getting vaccinated. If we go to the next slide, in 2022, for example, we observed that Black and Latinx individuals in the US were less likely to receive 4 or more COVID vaccine doses, which at the time meant that they were less likely to be fully vaccinated according to the clinical guidelines at that time. Guidelines have changed a little bit. Right now, we're focusing mostly on people getting the most recent dose available per clinical guidelines, so it changes year over year. But at this time, that's how we were measuring it. And we found that factors relating to structural exclusion from essential economic resources were almost universally linked to lower likelihood of receiving these vaccine doses. So for example, individuals without US citizenship, those living in poverty, experiencing food insecurity, lacking a regular source of healthcare or health insurance, were at least 40% less likely to receive those 4 doses compared to persons that were more affluent, and that inequity was broader or stronger in certain populations. And this kind of leads us to, after talking about these barriers that could act as almost practical barriers, how we can think of how system alignments may help us reduce these vaccine inequities. And here I'll pass it back to Amanda.
Thanks, Jenny. I think the computer has a mind of its own in some ways. It was advancing the slides before I was even ready. So I'll if you see it go forward, I'll just pull it back. So thank you so much, Jenny, for setting up the context for the intervention that we're studying in our project. So based on the emerging evidence that vaccination strategies need to anticipate and support a range of determinants of health, and that of the kind of complex mechanisms that we understand to be underlying inequities in vaccination access, there is indication that vaccination strategies that leverage community-based organizations and that support assistance across multiple needs can support access and equity in access to vaccines. And we see this evidence emerging in the literature, so documenting interventions that do seem to show promising results in supporting equitable access to these seasonal vaccinations, which we understand to be so important. And so that leads us to the intervention that we're studying in the current project, the Aging and Disability Vaccination Collaborative. So this program is an ambitious 2-year program that acknowledges that older adults and people with disabilities, as Jenny reviewed, the evidence face disproportionate risks from respiratory illnesses. And unfortunately, continue to have relatively low uptake of updated vaccines, which can offer such important protection from poor health and from the mortality risks that go along with these seasonal respiratory illnesses, specifically influenza and COVID-19. So the purpose and rationale for the Aging and Disability Vaccination Collaborative, or the ADVC, which is how we'll refer to it going forward in this presentation, is that supporting community-based organizations to undertake community-focused interventions can can support reaching people who faced additional barriers to accessing vaccinations. So, and these additional barriers include aspects of identity that Jenny mentioned, including race and ethnicity, also including LGBTQ communities, also including populations that have lower incomes, that might have limited English proficiency, that might be at risk of institutionalization, or that might live in rural areas. So really taking a broad concept of the types of barriers that might prevent access and trying to align systems, explicitly look at linking up public health, community-based social service organizations, and healthcare organizations to improve vaccination access. So the system alignment approach, to give a little bit more background on this program that we're working to study, is a program that was initially funded by the Administration for Community Living through a substantial federal grant that went to US Aging, so our research partner, to create and host the Aging and Disability Vaccination Collaborative. So that began in 2023, and what that consists of is US Aging actually made a bunch of grants, actually pushed most of that funding right out the door to over 160 sub-grantee organizations in communities across the United States. Those organizations were primarily organizations that focus specifically on populations of older adults in the communities or populations of people with disabilities. So area agencies on aging, centers for independent living, as well as other nonprofit organizations that support older adults and that support people with disabilities at the community level. And what those community-based organizations did in these hundreds of communities across the country is they developed tailored local strategies to try to improve awareness around the benefits of seasonal vaccinations for COVID, influenza, as well as some other vaccine preventable illnesses, which we'll detail in a few minutes. So trying to raise awareness and provide accurate, tailored information to populations who would benefit from these seasonal vaccinations. In addition, these organizations played really important roles in actually creating vaccination events that sought to overcome, kind of intentionally overcome barriers that people might face in accessing vaccinations. And really enabled hundreds of thousands of vaccinations. That's actually to preview that we've got some data on that. So the sub-grantees across the country were working on education, they were working on vaccination events, and this program is running from 2023 through 2025. So we're kind of in the second year of the program now. And to kind of link back to our hypothesized mechanisms by which the ADVC could disrupt racial inequities in vaccine access, we see the possibility of the work to provide accurate and tailored information about vaccines, and the approach of working with locally embedded community-based organizations as having strong potential to disrupt those channels that might suppress the intent of people to pursue vaccination. And alongside that, we see the potential for these vaccination events, which are intentionally designed to overcome practical access barriers, which can include providing support for transportation, providing support for caregivers, co-locating vaccination events with other types of services that people might be interested in, really intentionally thinking about convenience. Those mechanisms could disrupt some of the channels that prevent vaccination access for those people who do decide they want to pursue a seasonal vaccination. So now we're getting to the research that we're planning for this study. So we have two aims. AIM 1 is focused on descriptive analysis. So we're going to be examining the activities and partnerships associated with vaccinations provided by the ADVC, reaching minoritized populations, focusing on race and ethnicity. So that's the aim, where we actually have some very preliminary data that I'll share with you in a minute or two. And then the quasi-experimental aim of our project is going to look across the US and test whether vaccination rates for minoritized racial and ethnic populations increased in counties where ADVC recipients were located, so those community-based organizations that receive subgrants. And we're going to be comparing those locations that received ADVC grants with those places across the country that did not have an ADVC participant. So that piece of the study is actually going to get started next year. So we need to wait until the program is done. Then we're going to be acquiring the data we need for that study next fall. But in the meantime, we have actually a wealth of interim process data that we're already working to analyze to proceed with AIM 1. So today, what we will give you a bit of more detail on is some preliminary data where we have started to look at where ADVC was implemented. So getting a sense for what differences might exist between the counties where ADVC participants were located as compared to counties where they weren't located. So getting an understanding of targeting. I should note that the way these subgrants were allocated from US Aging out to these range of community-based organizations was largely based on, it was quite an open process. So community-based organizations could put together proposals, and then most of them were successful. So the idea was to support any organizations that were able and willing to do this work. But that being said, not every location had an organization that was kind of ready to step up to do this. So we're going to look at the comparison between where ADVC grants went and where they didn't. And then we have a wealth of data on where vaccinations were given, because grantees did a really comprehensive job of asking vaccination recipients to complete very basic non-identifying surveys for each person who received a vaccination at one of their events. So we don't have any information about that could be used to identify those individuals, but they were asked to do just a small number of questions about what vaccine they received and some demographic information. So race and ethnicity that they self-identified, age, and some other demographic characteristics. So we're able to use this to understand who was reached, what vaccines they received. And then we also know some information about the strategies that had been used at the events where those folks received their vaccinations. So we know about what activities the organizations had used to encourage engagement. Encourage folks to come to the event. We also know what other services were offered alongside vaccination at those events. And we know the types of partner organizations that were involved in the event where those vaccinations occurred. And so what we can do today is give you a bit of illustrative data on these pieces. We are not at the stage of trying to draw any conclusions or infer causality. So that's a big caveat. I don't think I'm going to show you any statistical tests today. But what I thought would be useful for this type of a presentation is to share the types of data we have available, because since we're in the very early stages, helping, sharing the types of measures that we have available to us, we thought could be a great way to get more ideas that we might, not be thinking of to inform our analyses going forward. So to the first piece, we have run a comparison of the counties that were exposed to ADVC or not. So this is actually the only statistical test I have for you today. So this is a comparison of the counties where a community-based organization that was a prime grantee was located, or where a vaccination event was located. So that so there's slightly more counties than grantees. So there were 165 counties where one of those two conditions occurred. And there were many counties across the US that did not have an interaction with ADVC. So about almost 3,000. So there's about 3,000 counties in the US. About 5% of those counties had some ADVC work. About 95% of those counties did not. As many of you will be aware, the population is not evenly distributed across counties. So one thing to be mindful of is that the counties where ADVC was active were much more likely to be metro counties. So looking at the last couple of rows, they were more likely to be urbanized counties. Those counties are also counties that are more likely to have organizations that are prepared to apply and administer a program like this. So that's one thing to be noting, and that's really the area where we see the biggest difference between counties that participated in ADVC or had a grantee versus counties that did not. But we also see that counties where ADVC was active were generally more urbanized, more diverse, and in comparison to non-ADVC counties. They also had somewhat higher rates of COVID-19 vaccination pre-ADVC. So you could see under the COVID-19 vaccinations set of rows, we see some difference, not a dramatic difference when we look at first dose for older adults or even booster. But as we go along into the later boosters, we do see the gap opening up a bit more between those ADVC counties and the non-ADVC counties. So this is all information that is going to be important as we kind of take our analyses forward to just be mindful of the fact that there are some underlying differences in the populations that we expect to see in terms of where ADVC was active versus not. And then taking us into some of the data that we have gotten a chance to analyze on the vaccination events that actually were delivered by ADVC, we can see that a very large number of vaccines were administered. So we've so far just looked at the first year. So that's the 23-24 vaccination year. So usually a vaccination year is, it runs through like the August of one year through to the summer of the next year, but most seasonal vaccinations actually are administered in the fall and winter seasons. So this data goes through last March, so March of 24. And in that first year, 276,265 vaccines were administered by grantees and documented in these vaccine recipient surveys. Those vaccines went to 238,718 individuals. Some people received multiple vaccinations. And on the table on the right, you can see the breakdown of vaccines that were distributed through the ADVC events. A couple of things I'll point out are that flu vaccine was actually the most common vaccine that folks got through these events, but we also saw quite a number of COVID vaccines. So, over 40% of recipients receiving COVID vaccines, including a small fraction but important number of folks who were actually receiving their first dose of COVID vaccination. In addition, there were other vaccines that people got at these events. Those include a range of vaccines for conditions like RSV or shingles or other vaccines, especially those that are needed by older adults. So now when we look at the characteristics of individuals who received vaccinations at ADVC events, we can see that a large fraction of those folks were older adults, so almost 40% in the 65 and over category, about just over 20% in the 50 to 64 age group, but an important segment of the population in those younger age groups as well. And I think that's to be expected because these organizations, we remember, weren't only targeting older adults, but also a range of folks with disabilities of all ages. And in most cases, we're actually open to people of any age. Then when we look at the right chart, we can see that vaccinations did reach a range of folks in by race and ethnicity. We also know from this information that we did have a little bit more of missing data by race and ethnicity that tended not to be individual level missingness, but was clustered within events. So there were some events where we were missing this piece of information for most of the vaccine recipients, but we are seeing a diversity in terms of race, ethnicity of the populations that were getting reached at the events. We also can see that there was a pretty broad reach in terms of geographic region. It'll be important, hopefully you're already thinking this, like when we continue on with these analyses, important things we want to understand are going to be the extent to which those folks reached at these vaccination events were representative of the local communities where the events were occurring, whether folks were being equitably reached, or whether these vaccination events were even working to overcome some of these barriers that we talked about earlier, and doing an even better job of reducing disparities than we might otherwise see in the population. So we have a few more graphs. I think I'm going to leave those probably for our next time because I want to make sure we have a chance to talk about the next piece of our analysis when we get to the quasi-experimental study. So I'm going to toss it back over to Jenny to speak to this, and then come back next year and we'll tell you about more of our interim results.
Yeah, we have a lot more results that Amanda and her team have done, and it's super interesting. But yeah, I'll talk briefly about the next steps, which are definitely still in the planning stage. We're just because of how the data works. But regardless, we're about to kick off that second aim, which is a quasi-experimental study evaluating whether vaccination rates for minoritized populations increase in ADVC recipient counties after the programs began in comparison to those counties that did not, didn't have any grantees. I was trying to figure out the best way to phrase that. What we're gonna do is leverage IQVIA LRX claims from 2020 to 2025. This data represents more than 90% of all pharmacy claims. And at first glance, if you think pharmacy claims, you might not think that this ties directly back to like what we've just been talking about. But this data is very well suited for this study because more than 90% of all flu and COVID vaccines in the US among adults are received at retail pharmacies. This data also contains some long-term care. I think it's like 50% of long-term care claims, which is also important for some. If we go back to one of the key populations, older adults, they're captured through there. And we have to remember that these events, first they could happen in partnership with pharmacies. And also there were those two mechanisms which we discussed about how these programs could influence vaccination rates. And it's not just the direct provision of a vaccine, but it's also addressing some of these other barriers to having an intention to receive a vaccine. But regardless, the IQVIA data represents the vast majority of flu and COVID vaccinations in the US. And we will be deriving vaccination rates at the zip code level by dividing the total number of adults, maybe also splitting it out to older adults as well, in a given zip code by the number of people that received the flu and COVID vaccine for each relevant season from 2020 to 2025. And to answer our primary research question, what we more specifically plan to do is compare those zip codes and counties with ADVC grantees, or those 163 counties that Amanda talked about, to zip codes located in counties with no grantees, which is about 95% of counties in the US, and comparing the pre and post implementation of ADVC grantee programs. When you compare the pre and post, you're trying to get at what change happened because of this program specifically. So that's not a quasi-experimental aspect of it. We're just trying to get at the difference of vaccination rates for before and after the program in comparison to counties that did not have access to the programs. We will also estimate this effect overall and and by different racial ethnic groups. Specifically, what we'll look at is zip codes with a high share of Black, Latinx, Indigenous, and Asian or Pacific Islander populations, and assess whether and to what extent these programs increase vaccination rates in zip codes with large minoritized populations. And although IQVIA data itself does not have race ethnicity data, because of the legacy of residential segregation, a large share of minoritized racial ethnic populations reside within segregated zip codes. In the top 30 cities, that's about 70% of people that are Black and Brown living in a segregated area. Therefore, our proposed methods allow us to understand the impacts or the inequities by race ethnicity and the effect of these programs among these minoritized populations, even though we don't have race ethnicity itself in this very particular part of the second aim. And finally, even though it's really early in our research in these quantitative, not quantitative, but quasi-experimental parts of it, we also hope to identify the most effective strategies for reaching minoritized populations. So for example, using kind of these quant approaches that we just talked about now, and Amanda has also alluded to descriptively, we can try to evaluate whether certain strategies or programs are particularly successful in increasing vaccination rates within specific racialized populations. And Amanda kind of brought this on, so maybe she'll talk about it a little bit more in the Q&A. But there's also very rich qualitative data that the grantees have developed from themselves, including archival records of grantee approaches on what worked well and what needed improvement through just different mechanisms that the grantees were keeping notes for themselves. And in a more traditional approach, we could also potentially interview these grantees on lessons learned as they attempted to improve vaccination rates in minoritized populations. So there's just a wealth of additional steps that we could take, and we're figuring out what those might look like. But I'm going to pass it back to Amanda to wrap it up.
Thank you, Jenny. Yeah, so that I love that you mentioned that we're looking forward to hearing responses and questions you all might have. One of the types of questions we've already started going back and forth on within our team is like, what's actually going on in the ground? We are really getting more curious as we look at quantitative data, like what it actually means. We did not initially have a qualitative component to this research, but I think even over the first few months of the project, we've been appreciating that I think we're going to really try to do all we can to make some qualitative components happen, because this work is so important, and the work that the ADVC grantees have accomplished is so important. We want to learn as much as we can from it. And we're hoping that the evidence can be useful for a range of purposes beyond the study. So first of all, looking to provide evidence on impact of large-scale investments like this to promote vaccination equity. So that's really going to come from our second aim, that quasi-experimental piece of the study. We also want to be able to illustrate the impacts of the ADVC grantees' work locally. So really help to document the positive impacts that they have had. Then also we're looking forward to being able to parse out some of the specific approaches and strategies that these various CBOs used that were effective to close vaccination equity gaps and help to reduce those racial and ethnic disparities that we saw in vaccination access. that existing nationally. So we are anticipating, like any very large and heterogeneous program that takes place across the country, that there will be some events and some strategies that work better than others. And so this is an opportunity to really help to distill which strategies and approaches locally did appear to have more of an impact on closing gaps, and then be able to share those across organizations. So with that, I want to thank you. I especially want to thank our partners at US Aging for collaborating with us and allowing us to do this research. And with that, I would love to hand it over to Tracy Wilson and Jennifer Hammer at US Aging, who have made the ADVC actually happen.
Thank you so much, Amanda and Jenny, for your presentation, and we're just thrilled to be partners with you in this work. My name is Tracy Wilson. I'm the Director of Research at US Aging, and I'm joined here by my colleague, Jennifer Hammer, who's Assistant Director of US Aging's Aging and Disability Vaccination Collaborative. And just quickly, for those of you who may not know, US Aging is the national association that represents and supports the National Network of Area Agencies on Aging and advocates for Title VI Native American aging programs. So these are the local organizations that help older adults, caregivers, and people with disabilities to live in their communities and at home with optimal health, well-being, independence, and dignity. So through this grant that we received at US Aging from the Administration for Community Living, US Aging developed the Aging and Disability Vaccination Collaborative. And from the beginning, the ADVC team worked really hard to put systems in place that could track grantee activities at the organization, event, and individual level, as well as qualitative data from grantees and vaccine recipients, which has allowed us to report reach and share anecdotal impact stories. However, being a national nonprofit organization, capacity is always an issue. And so we are just so excited to be partnering with UC Berkeley and on the Systems for Action grant. It's giving the project team the capacity to do a deeper dive and really build the evidence for the impact of this work, which, as Amanda said, will hopefully encourage additional funding and investment in this area. So I'm going to turn it over to my colleague, Jennifer Hammer, just to give you some real life examples. And she's really the expert here. She's been with the ADVC since its inception. So Jennifer, take it away.
Wow, I love, thanks, Tracy. And I don't know about the expert, but I will do the best job that I can to let you just give you some insight into the work our grantees did, which is phenomenal. But I have to say, just listening to this presentation from this angle, I just have so much respect for all of the research work that's been put into this, and I can't wait to see the end results at the end of this project. But I think, maybe one of the things I just kind of wanted to give an overview of was some of the events. I think that really speaks to how people were reached, because as was presented, getting to these populations was important, and the trusted messengers were so important in this. And they really went and knocked it out of the ballpark, quite frankly, designing events that were culturally appropriate, sensitive, non-clinical, in places that were convenient to reach. A lot of them provided supportive services such as transportation, appointment setting, multiple touches, multiple, not just multiple languages with the flyers and advertisements that were made, but meals that had food that was familiar. So just an amazing array of events that got people in the door. We had our challenges, as anything in the vaccine world. It's not shocking that we had challenges. We had the end of the public health emergency. There's vaccine hesitancy, misinformation. The Bridge Access Program ended, but our grantees just kept rising to the challenge and creating events that got people the right information in a way that was accessible and meaningful to them, it was creative, things like, oh gosh, so there were karaoke parties, there were tax and vax events. They used faith-based organizations, synagogues, churches, to hold events. There were events in rural communities, school partnerships for to reach whole families that wanted to get vaccinated. A lot of piggybacking on events that were already scheduled. We had one that did a movie night, an outdoor movie night. And so if you came, you could see a free outdoor movie, get your vaccination, have some social interaction. So just really, really creative and fun events. And I love to mention the pet event too. People could get a vaccination for themselves and for their pet. And we know a lot of seniors, their pets are just a huge part of their life. So that was a really successful story that ended up, I think, getting a news spot on one of the local channels. So that's just kind of an overview. And there's so many quotes that are out there. One of the ones I could share with you right now about one of our rural populations, he said, "We're often the last to be thought of since we're so far away from the bigger cities. We mind our business, but then miss out on what others with better options have. This gives us a voice and a choice to live better. Thank you for bringing us together with other people and resources." I'll stop there for a minute just because I could go on for a really long time. I'm the qualitative data person to complement all of this incredible, or qualitative to complement all the quantitative data. But if there's questions, I'm happy to answer what I can.
Thank you so much, the UC Berkeley team and to US Aging for presenting today and talking about the importance of this work and talking a little bit about the partnership between the two. I think it's safe to say that we have reached the Q&A portion of the presentation. So if any questions came up for you during today's presentation, please put them in the Q&A box. If we don't have time to address them today in this session, we do always provide the questions to the research team and allow them the chance to respond, and we include those responses in our follow-up communication with you all. So I'm going to couple two questions that came in, and I think both of you did a great job of addressing this after the questions came in, but I'm wondering if maybe you have some additional things to respond to. But one of the questions is about more strategies that grantees found that have worked well in their different communities, which Jennifer, you were speaking to a little bit. And then also, let's see here, the questions are moving around. Can you provide examples of community engagement strategies sites have employed? You talked a lot about the trusted partnerships and messengers in those communities, and you talked about some really innovative and unique ideas of bringing people together and bringing them, I guess, to a certain site so that they can become vaccinated and build that sort of community. But one of the other questions is co-creation of materials too, which I wonder if you have anything else to add to those questions.
Sure. Amanda, go ahead.
Oh, okay. Well, no, I was going to actually say I could start with the basics, but then I was going to hand it right over to you. Well, okay, let me start by just briefly mentioning what we have quantitative data on, and then pass it over to Jennifer to provide some more richness to that. So we do have systematic data on the activities that were used to increase engagement in each of these events. So that's one of those slides that I skipped through just, for the purpose of time. But the categories that grantees documented were personally targeted modes of engagement. So that could include anything from phone calls to door-to-door inquiries. Then we have captured mass communication. So that could be like radio ads, television ads, billboards. We also have grantees that documented using financial incentives. So that can be really important. And actually our initial descriptive data does suggest that for reaching certain groups, that might be even more important. So we see some variation in that impact. So providing basically an honorarium for the time and effort it takes to go get a vaccine. Grantees also provided caregiver training, so for folks accompanying a vaccination recipient, and a range of other sorts of strategies. And let me now pass it over as promised to you, Jennifer.
Oh, sure. So, so incentives were great. Grantees got really creative, farmers market, gift cards, things like that to support their local communities. Uh, Lots of different, sometimes food, a meal, things like that, would get people to come to the events. We also, I should mention, we had 22 national partners engaged in this initiative. So across the Aging and Disability Network, they provided some incredible targeted support, got the word out to their networks about what we were doing. Provided a lot of translations and culturally competent material that was really, just incredibly useful to so many grantees. Training, we had de-escalation training for, if some of our grantees maybe encountered some folks who weren't real happy about what was going on. We were able to build out an entire resource hub that we kept updated for things that needed to be updated, like CDC recommendations, but also just a lot of really great evergreen material that grantees could just pull and quickly plug in, basic information about their events, and they didn't have to recreate the wheel or anything like that. And we also used, we have a national ad campaign called You've Got This, and you could go to the website and get information about what we were doing there and find a grantee. And then that was also tied into our national call centers that we have at US Aging, the Elder Care Locator and the Disability Information Access Line. And so if grantees had, called it, or I'm sorry, not grantees, if folks called into those lines, they could find a grantee in their area or get additional help to find a vaccine if there wasn't a grantee. So just, leveraging every network, other parts of our organization that we could to build out this network of materials and resources and multiple ways to find a vaccine.
That sounds extremely helpful for all of your grantees. And I love it. Sounds like you allow each grantee to figure out and have the authority to decide what activities and materials might make sense to best meet their community members, which is wonderful. I'm going to move on to the next question, and I'm guessing you're going to have a great answer for this. I don't think it was addressed in the presentation, but given that you're US Aging and the population that you're focused on helping, does any of the project of ADCV, vaccination access, focus on community living facilities and nursing homes?
No, we tend to focus on community organizations, and they're out in the community. So, and they partner with, pharmacies, consultant pharmacists, things like that.
Great, thank you.
And also
yeah.
just to add on that, the grant will be ending the spring, and so hopefully we will have we'd love to find some resources to be able to continue this work and build on the infrastructure that has been developed. But it's great to have this opportunity to demonstrate the impact of it.
Great, thank you, Tracy. Next question is, how do you plan to control for vaccination efforts in non-ADVC counties or zip codes?
Well, I can start, and Amanda, you'll fill it in a bit more than I will. So, two ways. We plan to control, like in terms of controlling for confounders, for a wide variety of characteristics at the neighborhood level. We'll also include zip code level fixed effects, which what that means is that for anything that's time invariant, so it doesn't change over the multiple years that we're looking at, it should be controlled statistically. That being said, what you're suggesting is time varying programming, which our approach may not be able to control for. I think I have to spend a little bit more time chewing on what does that mean in terms of biasing our results. If the risk is that attenuation is the primary risk, which means that maybe these events these type of events do work, and because we're not controlling for these other events in other counties and other type of similar strategies being used in other counties, it looks like what ADVC is doing doesn't really work, because we're not controlling for other types of events that are similar that are happening in other areas. I'm just not as I don't know how many of those type of events actually happen or programming happens to this type of large scale continuously over multiple years. In part, this is why we're looking at what US Aging is doing, because it's the biggest type of funding for this type of programming to improve vaccination rates. So yeah, it's definitely something to chew on. I don't think I have like the best, like we 1000% know how we're going to handle it yet. Amanda.
That was so that's the key stuff. And then maybe just to layer on one other piece and underline the element of the time. So I think the thing that we would worry about is if there was, so we're comparing each place to itself over time. So the thing that we probably worry most about is if there was some sort of vaccination strategy that selectively targeted places where ADVC didn't exist and kind of flattened out our comparison between intervention and control, so that if there was some vaccination promotion that occurred evenly across the entire country, all of our zip codes, I think we wouldn't worry too much about that. The thing we would worry about really attenuating a potential impact would be if there was some event or some activity that selectively invested in those counties and zip codes where ADVC wasn't active. We don't know, that would have to be pretty big, and we don't know of anything like that. But I think if there are ideas, or maybe if folks are thinking about ideas that might fit that criteria, do let us know, because that is something that we can add into our adjusters and controls.
That is a benefit in presenting in some of these research and progress webinar series. I think maybe we can include your emails in our follow-up email that we send to attendees, so that if they have any thoughts on that, they can reach out to you. I'm going to use moderator's privilege here to skip to the last question that came in, because this is a question that I had in my back pocket in case we didn't have enough questions coming in. But Dr. Timothy says, wonderful presentations. What strategies are emerging to counter the potential anti-vax posture of the incoming presidential administration? And I know you talked a little bit about the anti-vaccination strategies that you had in this presentation, but I'm wondering if you're thinking about that and talking about how that might change over the next 4 years, given the incoming president.
Yeah, I mean, we are all about empowering people to make their own health choices with the right information, right? So we're going to continue. I would actually say we probably wouldn't change a whole lot. We continue to provide the information, the best information that we have that comes directly from the CDC, update the materials, present them in a way that is, through all of these events, culturally competent, sensitive, through trusted messengers. So there's not really, there's nothing, I think that we're really changing a whole lot in this upcoming year, other than just keep doing what we're doing. Yeah.
Great. I think that is the benefit of being trusted partners in the community, right? Like, you've put a lot of time into this and have built that relationship, which is necessary. Did anyone else have anything to say on that question, or are we okay moving to the next one? Okay, I think we have time for one more question. So I'm going to ask Sean's question, because that came in first. Great work. Looking forward to your next steps, which Systems for Action will keep you updated on all future research and progress webinars. But what, again, was the statistic about where most vaccinations are administered, and where did that statistic come from?
You might, Jenny, maybe this is one you presented.
Yeah, I think is the one. I think I just said it verbally. Yeah, so it comes from the CDC. And what they look at is claims for vaccinations and where that actually happened. But there's a distinction between vaccines and that second name, where we're trying to get as many national vaccinations, and this data is likely representing over 90% of all vaccinations for influenza and COVID-19. But then there's the events that ADVC grantees host, and that's a different kind of statistic. It depends on the partner that's used for the event, because it's not the community-based orgs that are doing the vaccinations themselves. They partner with someone else to do that. Yeah, Amanda, I think you could comment on that.
So then that piece around that, the vaccination national data that we're going to be using for AIM2 is, I think the piece that Jenny mentioned, that stat. We also have a statistic that you may have seen briefly flash on the screen as far as where the ADVC vaccinations were administered. So we do know that a majority of those vaccinations were administered in community events, so like public settings, where folks could come in a congregate area, but an important minority of the vaccinations were delivered in homes. So about 9,500 vaccinations actually occurred in home, and that was, I think, especially important for folks who might have disabilities or otherwise find it more difficult to get out to a public event.
Great. Thank you. I think in respect of everyone's time, it is time to go ahead and wrap up for today. But thank you so much for coming and presenting, and thank you everyone for attending and listening to the exciting research that this team is going to be working on over the next 2.5-ish years. Like we mentioned, this is an ongoing series. This team will come back and present again in the middle of their project. We have all of the emails of people who registered for this event, so we will definitely email you to let you know about their next presentation. And we will include information about our next Research in Progress webinar series from our team at American Institutes Research and our follow-up communication, which will include the slides and recording from today. So thank you so much for joining. I hope everyone has a lovely rest of their Wednesday.